Yeah, today we will be discussing about the pulmonary venous abnormalities. The importance of these pulmonary venous abnormalities are, it is one of the common diagnoses to be missed. And second thing is, most of the diseases are quite serious, that if we don't correct them, they will end up in substantial morbidity. So if you look at what is a normal pulmonary venous drainage, normally there are a couple of pulmonary veins that drain into the left atrium from the right lung and another couple of them from the left lung. It's important to understand the anatomy on echocardiography. If you see on parasternal short axis view, there are two veins that are coming on the left side. The one on the top is the upper pulmonary vein and the one on the bottom is the lower pulmonary. We need to have a clear understanding about why what we see anteriorly on a parasternal short axis view is upper and what we see posteriorly on a parasternal short axis view is lower. So for that, this is parasternal short axis view of the upper and lower pulmonary vein. So this is the suprasternal view. This is also called as the crab view. So here, the one on the top are the two upper pulmonary veins and one on the two are the two lower pulmonary veins. If you see the CT angiogram and look at the posterior surface of the heart, the right superior and right inferior pulmonary veins, the left superior and left inferior pulmonary vein all drain onto the left atrium. Let us now see this is the posterior wall of the heart. This is a model with the two pulmonary veins posteriorly on the right side and two on the left side. So we are going to be concentrating on these four pulmonary veins. We know that the upper pulmonary veins on the right side, which drains the upper and middle lobe, is above the major fissure, and the lower pulmonary vein, which drains the lower lobe, is below the major fissure. So this is the right lung and this is the major fissure. So the major fissure is also called as the oblique fissure, and so the upper and the middle lobe automatically come as the anterior structure and the lower lobe comes as the posterior structure. So what we call as an upper pulmonary vein is also an anterior pulmonary vein, and what we call as a lower pulmonary vein is also a posterior pulmonary vein. The same thing if you see here, the left side, this is the major fissure or the oblique fissure. So the entire upper lobe and the lingular lobe is anterior and the lower lobe is posterior. So the lower pulmonary vein is posterior and the upper pulmonary vein is anterior. Another thing I want to show you in this anatomy. The pulmonary vein is anterior to the pulmonary artery. I'll go back to the right. The same thing. The pulmonary vein will be anterior to the pulmonary artery. This has got certain important connotations. I will come to it later. So now, if you see, these are the four pulmonary veins. The four pulmonary veins drain into the left atrium, and the blue color is given by the upper pulmonary vein because the upper pulmonary vein is also anterior. The red color is given by the lower pulmonary vein because lower pulmonary vein is also posterior. So that is the reason why, irrespective of whether we do a suprasternal view or a parasternal short axis view, the blue color will be taken by the upper pulmonary veins and red color will be taken by the lower pulmonary veins. It is important to document these four pulmonary veins in every cardiac echocardiogram that we will be doing. So to once again to orient with the CT angiogram, you see that the upper pulmonary vein is an anterior structure and the lower pulmonary vein is a posterior structure. This is the vertebra. This is actually an MRI. This is the vertebra. This is a white blood image. This is the aorta. See, the upper pulmonary vein is an anterior structure, lower is a posterior structure. Here again, upper is an anterior and lower is a posterior. So this concept we all need to get it very, very clearly. Now about what is a normal Doppler trace. We have got a systolic wave, a diastolic wave, and an atrial reversal wave. Normally, the systolic wave is a bit prominent than the diastolic wave, and the atrial reversal is seen during the PR segment. So this is the normal pulmonary venous Doppler. Sometimes you will find two systolic waves and two diastolic waves, something similar to even hepatic veins. But whatever is corresponding to the PR interval is the atrial reversal. If you are having a diastolic dysfunction, the systolic wave becomes a little less, the diastolic wave becomes a little bit more prominent, and the atrial reversal also becomes more prominent. And whenever there is a mitral regurgitation, the more and more severe the mitral regurgitation, the systolic wave will have a reversal. So this is the importance of understanding the pulmonary venous Doppler patterns. The normal Doppler pattern will have a systolic wave more than the diastolic wave, and the atrial reversals will become more prominent in diastolic dysfunction. Now coming to the pulmonary venous abnormalities, the prototype of pulmonary venous abnormalities is the anomalous pulmonary venous connection. TAPVCs account for about 1% of congenital heart diseases. Not many syndromes are associated with TAPVC, with two exceptions. One, all the heterotaxis, especially the right isomerisms, are associated with TAPVC. This is also called as the eye mark syndrome. The second one is abnormalities of the short arm of 4 and 5 gets sometimes named as cat eye syndrome. Basically, it is due to coloboma of the iris, which gives the eyes a cat-like appearance, and associated with it, there may be TAPVC. Otherwise, TAPVC by and large is not associated with any other problems. And that is the reason why if you operate on a TAPVC and they don't get any pulmonary venous obstruction, these people will have a completely normal post-operative natural history. TAPVCs are classified into supracardiac, intracardiac, and infracardiac TAPVC. Supracardiac accounts for about 50% of the TAPVC. Supracardiac TAPVC is the commonest type. Of the supracardiac TAPVC, the left vertical vein draining into the left innominate vein is the commonest. Almost 90% of the supracardiac TAPVCs are left vertical vein. So this is what is commonly described as the figure of 8 appearance on the chest X-ray, where the figure of 8's upper ring of the 8, which is occupying the superior mediastinum, is formed on the left side by the vertical vein and right side by the dilated right superior vena cava. Sometimes it will be a right vertical vein draining to right superior vena cava. Sometimes it will be a right-sided azygos vein. Sometimes it will be a left vertical vein which ascends up but drains into LSVC and then finally drains into the coronary sinus. So for a supracardiac drainage, it should be above the heart, and so there are only two possibilities. One is into the right superior vena cava or into the left superior vena cava. And if it is into the left vertical vein, it can drain through the left innominate vein or through the coronary sinus back into the right atrium itself. Or it can be a right vertical vein going to the right superior vena cava or right-sided azygos. Intracardiac are of two types. One is the coronary sinus and second is the right atrial type. And the third one is infracardiac. This is the classical supracardiac TAPVC which causes the figure of 8 appearance. So this shadow is the upper portion of the 8 and this shadow is the lower portion of the 8. It's also called the cottage roof appearance or snowman appearance. This is the commonest form of TAPVC. So this is the echocardiographic appearance of the TAPVC. You can see that all the 4 pulmonary veins converge to form a common chamber. The common chamber on the leftward side and drains into the left innominate vein and drains finally down through the right superior vena cava. You can also appreciate that the entire flow is laminar, which means it is not obstructed. It's important to understand one thing. I already showed on the CT angiogram that the pulmonary veins are anterior to the coronary angiogram. So if the pulmonary veins are anterior to the pulmonary veins which join the common chamber will also tend to course anterior to the left pulmonary artery. So this is the short axis right pulmonary artery and left pulmonary artery. This is the left vertical vein and it is anterior to the left pulmonary artery, so it is not getting obstructed. So if you are finding a left pulmonary artery, that the left vertical vein that is anterior and to the left of the left pulmonary artery, it doesn't get obstructed. So this you see here, this is the 2 pulmonary arteries and the left vertical vein is not getting obstructed. However, imagine the situation if it is posterior, then it may get obstructed. That is what is called hemodynamic voice. What is the clinical presentation of this most common form of TAPVC? Even if there is no obstruction, the circuitous long path from the pulmonary vein to the AV valve adds to the resistance in the circuit. A long channel, if it is unassisted by a ventricular pump, it is going to cause a lot of resistance in the circuit, and that is the reason why many of the unobstructed TAPVCs also have significant pulmonary hypertension. Now the corollary for this is, if you are going to be having all the 4 pulmonary veins draining directly to the posterior wall of the right atrium and that is causing a TAPVC, that patient will not have the same degree of severe pulmonary hypertension what a supracardiac TAPVC is going to have. So it's important to understand that PAH is contributed to a large extent by the long circuitous path itself, compounded by additional pulmonary blood flow. Most of these patients are cyanotic heart diseases with increased pulmonary blood flow. So this additional pulmonary blood flow adds to the agony. Older survivors, whoever is developing pulmonary hypertension will die. So the natural history is very poor. 90% of TAPVCs die by the end of 1 year. So if people are surviving, that means those are the patients who do not have pulmonary hypertension. So the older survivors will have very mild pulmonary hypertension only. Now, I briefly mentioned about the left vertical vein getting obstructed by the bronchopulmonary valve. Now you see what is happening. This is the 4 pulmonary veins joining together to form the common chamber. And as we are just sweeping from the pulmonary artery, just behind the pulmonary artery, it is getting crushed by this is the vertical vein. It's getting crushed by the dilated pulmonary artery. So here, the ascending left vertical vein is posterior to the left pulmonary artery. So it is between the left pulmonary artery and the left bronchus. It is also called as hemodynamic valve, or it's also called as bronchopulmonary valve. So if there is a hemodynamic valve, the pulmonary vein, which is a soft walled structure, gets squeezed between the left bronchus, which is a cartilaginous structure, and left pulmonary artery, which is a very pulsatile structure, and so this results in obstruction. The funny part of this obstruction is, it is not a fixed obstruction, it's a dynamic obstruction. Why? If a patient is having a mild degree of obstruction, that mild degree of obstruction when the child is quite sleeping may lead to minimal gradient, and it may not cause any major problem. Now imagine the child wakes up and cries out. There is an increase in the cardiac output. The increase in the cardiac output results in increase in the pulmonary venous flow through this narrow orifice. This leads to increase in pulmonary venous obstruction. This causes secondary increase in the pulmonary arterial hypertension. This pulmonary artery now becomes more distant. So the pulmonary artery pressure, when it increases, the PA sizes increase, it squeezes this left vertical vein further. This additional obstruction of the left vertical vein caused by the dilatation of the left pulmonary artery leads to more obstruction. The increasing obstruction leads to more distress for the baby, and so the baby cries more due to breathlessness. And that crying and that agitation leads to further pulmonary hypertension. And that pulmonary hypertension leads to further left pulmonary artery enlargement. So this becomes like a vicious cycle, and in that cycle, the child may die. That is the reason why an obstructed TAPVC has got an extremely high mortality, and that is one of the reasons why we say the moment we diagnose pulmonary like TAPVC, immediately try to operate. So it's important to understand this hemodynamic wise concept, and it is posterior to the left pulmonary artery, between the left pulmonary artery and the left bronchus. So this is how, this is the left pulmonary artery. The left pulmonary artery squeezes this vertical vein and results in obstruction to the pulmonary vein. There will be significant gradients. So the gradients here are almost up to 20 millimeters of mercury peak. So it's quite a lot of pulmonary venous obstruction can be produced by the hemodynamic valves. But we should also remember that obstructed left vertical vein TAPVC does not mean always a hemodynamic valve. Sometimes you will have the pulmonary veins coming anterior to the vertical vein coming anterior to the left pulmonary artery, but the obstruction will be at variety of levels. See here, this is a dilated superior vena cava, and where it is draining into the right atrium, that orifice is very small. So superior vena cava right atrial junction obstruction, and that is leading on to obstruction. So this is a narrowing of the SVC-RA junction. So that can be an obstruction. So here the obstruction is at this place. Sometimes the obstruction will be at this place, where the left vertical vein joins into the right left innominate vein. That junction can be obstructed. It's important to note what are all the common sites of obstruction, because on echocardiogram you have to use like a checklist and identify, is this common chamber hypoplastic? Is the pulmonary vein hypoplastic? Is this left vertical vein obstructed by a hemodynamic vice? Is this left vertical vein obstructed at the level of vertical vein to innominate vein junction? Is the right superior vena cava obstructed at the superior vena cava atrial junction? Is the PFO restricted? So these are the 6 areas where the left vertical vein TAPVC can get obstructed. So it's like a checklist. You go and identify what is happening here. This is the right atrium, right ventricle, left atrium, left ventricle. Intratrial septum is thoroughly bowing into the left atrium. What does this mean? That means the PFO is restricted. That means the right atrium is at a much higher pressure than the left atrium. So this is an indirect evidence of PFO being smaller. So then you go into the subsified view, you will find that this is the right atrium, the left atrium, the intratrial septum, the septum secundum is bowing into the left atrium, indicating that it is quite small. So the obstruction can be at the level of PFO. So varieties of reasons why this is obstruction at the level of PFO. This is another patient with a left, like classical supracardiac TAPVC. You see that there are 2 pulmonary veins that are draining. There is a common chamber here, and there are 2 pulmonary veins that are draining. This is the left upper, this is the left lower, this is the right upper, this is the right lower. All are ascending up, but what is the difference? It's very small. The entire thing is very small. Nothing is bigger. The previous echo, you saw the common chamber was like a big chamber here, huge vessel. No, here everything is very small. So the same left vertical vein, but the whole of the common chamber is very small. See the size of the pulmonary artery and size of the common chamber. The common chamber is extremely small compared to the pulmonary artery size. So that means here, this is a diffuse small size of the pulmonary veins and the common chamber, and that can result also in significantly high pulmonary hypertension. So it can be a uniformly small common chamber, uniformly small pulmonary veins, small left vertical vein, and that can also be one of the reasons for obstruction. So the commonest form of TAPVC is supracardiac. Drainage is often into the left vertical vein. PAH can be without any obstruction, just due to high pulmonary blood flows, high fetal pulmonary vascular resistance, because this is a long circuitous pathway which itself adds to the resistance. If there is an obstruction, it can be due to pulmonary vein and common chamber hypoplasia, discrete obstruction of the left vertical vein, bronchopulmonary vice, or it's also called a hemodynamic vice, right superior vena cava to RA junction obstruction, or a small PFO. I explained why this bronchopulmonary vice is called a hemodynamic vice, because it's a condition that aggravates its hemodynamics by itself. So child cries, PA gets distended, more obstruction, more pulmonary venous hypertension, more breathlessness, more the child cries, more obstruction. So it is like a vicious cycle. The surgery for supracardiac TAPVC of this type is anastomosis of the common chamber to the posterior wall of left atrium. It is done by 2 methods. One is called as the Schumacher's repair, and second is called as the Tucker's repair. Basic difference between the two is, in Schumacher repair, you make an incision on the anterior wall of the common chamber, posterior wall of the left atrium, open it like 2 chambers, and anastomose side to side. In Tucker's repair, cut the right atrium, go into the intratrial septum, cut the intratrial septum, go into the posterior wall of left atrium, cut the posterior wall of left atrium, then you will see the posteriorly the common chamber. Cut the anterior wall of common chamber, anastomose it, then come back to the atrial septum, close the atrial septum, come back to the RA wall, close the rest. So it's basically just a technical difference between the two, but both achieve the same purpose. What happens after this anastomosis? Most of the time the anastomosis is quite roomy and it does not get obstructed. However, in some patients, this anastomosis, if it becomes smaller, it can result in significant anastomotic gradients, lead to pulmonary venous persistent hypertension and secondary pulmonary arterial hypertension. So this is the parasternal long axis view, aorta, left ventricle, left atrium, common chamber, anastomosis site, and there is a continuous turbulence. So this is the apical four-chamber view. Right atrium, right ventricle, left atrium, left ventricle, common chamber to LA anastomosis, which is obstructed. So what is the effect? This is resulting in pulmonary hypertension. So the right ventricle is getting distended, interventricular septum is bowing into the. So this is secondary pulmonary hypertension due to pulmonary venous obstruction. Let us move on to the other three types of supracardiac TAPVC. I told there is right vertical vein TAPVC to right superior vena cava, or azygous vein to right superior vena cava, or left superior vena cava to coronary sinus. Each one will see. This is the right vertical vein to right superior vena cava. So this is the right pulmonary artery. Often the right vertical vein courses posterior to the entire hilar structures of the right lung. So right hilum will have pulmonary veins, pulmonary arteries, and the bronchus. So the entire channel will course posterior. Right vertical vein is a posterior structure and goes and drains into the posterior wall of the right superior vena cava. So this results in flow of the blood from the common chamber through the right vertical vein and just turning around and draining into the right superior vena cava. This is a subsequent short axis view. So this is the posterior structure. This is the anterior structure. So in other words, this is the right vertical vein. This right vertical vein is posterior to the right pulmonary artery, right bronchus, and goes and drains into the right superior vena cava. Anastomosis of the common chamber into the left atrium by surgery is the same like left vertical vein TAPVC. This is the right azygous vein TAPVC. All the four pulmonary veins join together, go through the azygous vein and drain into the right superior vena cava. Now, there is a subtle difference between this right azygous TAPVC and right vertical vein TAPVC. If you see right azygous vein, in the fetus, it is not a very big structure. And so most of the time it will be obstructive. In the fetal life, this does not become very large because after all it is a posterior cardinal vein. So it doesn't become very large, and so after the baby starts to have a fall in the pulmonary vascular resistance and increasing pulmonary blood flow, this azygos does not accommodate a large flow, and so very often it will be restrictive. So this is an azygos form of TAPVC, and here you will find that most of the time this channel is smaller, and so there will be some restriction. So the restriction produces some gradients. The last type of supracardiac TAPVC is all the four pulmonary veins join together into the LSVC, but there is a persistent LSVC and so it drains into the coronary sinus. This is the unusual form of TAPVC. So here you see the four pulmonary veins coming together and ascends up, but it is draining into a large LSVC. And so instead of the left vertical vein going and joining the left innominate vein, it just comes down into the coronary sinus. So this is the vertical vein coming into the LSVC, and from the LSVC it is draining back through the coronary sinus back into the right atrium. So these are the common forms of supracardiac types of TAPVC. Now coming to the cardiac types of TAPVC. Coronary sinus is the cardiac type of TAPVC, is around 20% of all the TAPVCs. Coronary sinus is the commonest form of TAPVC. Coronary sinus accounts for almost 75% of the cardiac type of TAPVC, and right atrial type is less common. It accounts for about 25% of the cardiac type of TAPVC. The right atrial type of TAPVC most often is associated with right isomerism. Most of the cardiac TAPVCs are in general unobstructed. I already mentioned the reason. The pathway between all the four pulmonary veins into the cardiac chamber is very short. So when it is short, there is no resistance. Most of the time it is not obstructed. This is coronary sinus TAPVC, where all the four pulmonary veins drain through the dilated coronary sinus into the right atrium. And you can see some flow turbulence. However, if you look at the anatomical pathway, it is not obstructed. So most coronary sinus TAPVCs are not obstructed. So this is how a coronary sinus TAPVC comes, and there is a PFO or an ASD to allow the right atrial blood to go into the left atrium. Even though most coronary sinus TAPVCs are unobstructed, some of them will have severe pulmonary hypertension because they have very small left atrium. So if you are having a patient with coronary sinus TAPVC still with high pulmonary pressure, look at, is the left atrium adequately developed? see the size of the left atrium, it's 1.2 centimeters. You just can compare, it's almost 4.5 centimeters of the right atrium, so 4 times bigger. So if the size of the left atrium is smaller, that can result in pulmonary hypertension. Very rarely, the 4 pulmonary veins that come and drain into the coronary sinus, the anastomotic area where the place where the common chamber joins into the coronary sinus may be narrowed and can produce an obstruction. But this form of obstruction of the common chamber into the coronary sinus at this area is little uncommon. So in coronary sinus TAPVC, the coronary sinus in the left posterior AV groove appears very dilated. The surgical repair will be unroofing this coronary sinus into the left atrium. That means you cut the roof of the coronary sinus, you lay open the entire coronary sinus into the LA, and then patch close the second MASD with ostium of the coronary sinus all together with one redundant IAS patch. Why I am telling redundant IAS patch? If you use a rigid IA, like a very short intratracheal septal pericardial patch, there won't be any room in the left atrium. That will lead to secondary obstruction. I'll show an example. This is the coronary sinus TAPVC. Originally, the coronary sinus was draining into this right atrium. And there was a fossa ovalis ASD here, which was communicating from the right atrium into the left atrium. The surgeon did the patch closure of the entire fossa ovalis ASD and the ostium of the coronary sinus. However, he did not unroof the coronary sinus deeply. If he has unroofed the coronary sinus entirely along the entire pathway, this coronary sinus would have freely egressed into this left atrium. However, now what is happening? The coronary sinus blood is coming here, and through this small orifice, it is entering into the left atrium. So this is resulting in post-operative severe pulmonary hypertension caused by inadequate de-roofing of the coronary sinus. This particular repair is called as Van-Praag's repair, and if you don't adequately do a coronary sinus de-roofing, it will result in pulmonary venous obstruction. Last type is right atrial form of TAPVC. All the 4 pulmonary veins drain onto the posterior wall of the right atrium itself. This is caused by a malalignment of the atrial septum towards the left side. You see, this is the septum primum. It is just shifted towards the left side, and that results in all the 4 pulmonary veins to be selectively draining into the posterior wall of the right atrium itself. So this is the left pulmonary vein, the right pulmonary vein, everything draining into the right atrium, and through the PFO, the blood is going into the left atrium. Repair involves baffling of the pulmonary vein entry towards the mitral valve orifice. The cause of right atrial TAPVC is due to malalignment of the primum septum. If the primum septum is deviated to the left side, the left-sided deviation results in all the 4 pulmonary veins to be committed to the rightward side of the atrium, and that results in right atrial form of TAPVC. So this is right atrial form of TAPVC. In fact, the atrial septum should have been like this, but instead of this pathway, this primum septum is deviated leftward. So this is leftward malalignment of the primum septum. That is the basic pathology of right atrial form of TAPVC, and this is quite common in some of the heterotaxy syndromes, like especially the left isomerisms. Right isomerisms are associated with supracardiac or infracardiac TAPVC, whereas left isomerisms are associated with intracardiac TAPVC. The last, sometimes there can be some unusual forms of TAPVC. You will find that there is a dilated right superior vena cava, and there is some form of a right vertical vein. You will feel that this is a right vertical vein TAPVC. However, I'll show you an example. This is you are injecting into the pulmonary artery. You see what is happening. The pulmonary veins come up now, and this is the pulmonary veins. The pulmonary veins come down towards the diaphragm. You see now it is descending towards the diaphragm, then ascending up as an azygous vein and draining finally into the right superior vena cava. So the basic problem is it drains down towards the diaphragmatic surface, drains into the azygous vein, and from the azygous vein then finally goes into the right superior vena cava. So we should be aware about TAPVC is having some bizarre structures. Basically, embryologically, if you see, all the TAPVCs are caused by abnormal communications of the developing pulmonary veins towards varieties of cardinal veins. So it can go in any pathway, and so there is no stereotyped appearance of a TAPVC, and hence, if there is anything in doubt, immediately we should go for further imaging. Infracardiac TAPVC is also called as infradiaphragmatic TAPVC. The classical hallmark is a vertical vein that courses anterior to the aorta and courses down towards the infra-abdominal portion, very often drains into the portal vein, sometimes into ductus venosus or hepatic vein or inferior vena cava, but the most common site is into the portal vein. The way to differentiate between the aortic flow and the pulmonary venous flow: pulmonary venous flow will be continuous, whereas aortic flow will be pulsatile. So this is the cartoon of all the four pulmonary veins draining into the portal vein. So there is an obligatory obstruction at the liver parenchyma. The blood has to go through the entire hepatic sinusoid and then come back into the hepatic vein. Rarely you will have a direct communication between the portal veins to the hepatic vein through ductus venosus, and in such patients, if you treat them with prostaglandin, suddenly there will be an improvement. The pulmonary venous obstruction will be relieved and they will open up. Otherwise, infracardiac TAPVC is considered to be a condition where prostaglandin is contraindicated. If you see a child with cyanosis, blindly you can start prostaglandin. All cyanotic children will benefit with prostaglandin. Exception is an obstructed infracardiac TAPVC, because the additional pulmonary blood flow caused by the vascular dilatation will result in more and more venous return and more pulmonary venous obstruction. But the ductus venosus also is dilated by prostaglandin. So suddenly some patients will have on prostaglandin a very favorable response, and they will become markedly better. And such patients are due to the opening up of the ductus venosus. Infracardiac TAPVC, the chest X-ray will be similar to hyaline membrane disease, white out lungs, but we have to remember one thing: patients with markedly high pulmonary vascular resistance may have dark lungs also. So always we should not think that it is white lung. There can be very dark, black-looking lungs also. And so such patients are very sick with very low saturation. Mixed TAPVC, the mixed TAPVC is also seen in about 10% of the patients. It's very important to identify this condition. This is a coronary venous TAPVC. See that it's looking, having all the features of a coronary venous TAPVC, but you go and do a suprasternal view, left upper pulmonary vein is draining separately into left vertical vein. So mixed TAPVC is a combination of coronary, like intracardiac and supracardiac, infracardiac and intracardiac. Varieties of combination can occur. It's important to understand it. TAPVC should be addressed surgically immediately, and surgery involves anastomosis of the pulmonary veins into the left atrium. Now coming to the rarer varieties, triatriatum. This is an obstructive membrane in the left atrium which separates the mitral valve, mitral orifice and left atrial appendage anteriorly and the pulmonary veins posteriorly. This results in severe pulmonary venous hypertension. Two associations: one is atrial septal defect and second is abnormal pulmonary venous drainage. So this is a classical example for triatriatum. So this is the car membrane. This partitions the left atrium into superior chamber and inferior chamber. Very often the superior chamber will be hypertensive because of the obstruction, and that results in downward movement of this obstructive membrane very close to the mitral valve, and that is one of the reasons why people ask for triatriatum as a differential diagnosis for supramitral membrane, because sometimes this can be pushed so much down that you will find this membrane almost on the top of the mitral valve. Then will come the question of how to differentiate between triatriatum and supramitral rim. Or differentiating between the two structures, we need to recognize that this intervening chamber will have the left atrial appendage in triatriatum, whereas if it is a supramitral membrane, the left atrial appendage will be above this structure. So this is the echocardiogram with Doppler showing the obstruction. There is only a very small orifice. So this causes severe pulmonary venous obstruction, and the venous obstruction is as severe as peak of 33 and mean of 80. And this is the peristernal long axis showing the obstruction of the left atrium. Sometimes triatriatum can be partial. That means only the right pulmonary vein, or only the left pulmonary vein, or only upper pulmonary vein. It can be very, very selective membrane. So this is an example of the patient who presents with a turbulence in the left atrium. Left pulmonary vein, the lower pulmonary vein is looking very big here, but suddenly there is a turbulence here. So this is not pulmonary venous obstruction. If it is a pulmonary venous obstruction, this vein itself will be small. Now the vein is distended, but the turbulence is coming like a fire within the left atrium, and we are not able to see a clear-cut membrane. If you go into the transcatheter electrocardiogram, you will find this is the right atrium, this is the aortic valve. This is the region where the right pulmonary veins are draining into the left atrium, but there is an obstructive membrane. This membrane results in gradients between the right common pulmonary venous orifice to the left atrium. So this is partial triatriatum. So we need to remember triatriatum can be partial or complete. Triatriatum may also coexist with anomalous pulmonary venous drainage. So this is the triatriatum, right atrium, left atrium, upper chamber, lower chamber with the triatriatum membrane, and then this is the same patient, a membrane, upper chamber, lower chamber. You look at the suprasternal view, that upper chamber is completely decompressed by a left vertical vein also. So triatriatum can be associated with atrial septal defects and can be associated with abnormal pulmonary venous drainage. Just for the sake of curiosity, that is triatriatum dexter, that means right-sided triatriatum. You see there, the Eustachian valve becomes prominent, goes and gets attached to some superior portion of the right atrium, thereby partitioning the right atrium into two chambers, one anterior chamber, one posterior chamber. So this is called triatriatum dexter. It's not of major functional significance. Pulmonary vein stenosis is the last part. It can be single pulmonary vein stenosis or multiple pulmonary vein stenosis or complete pulmonary veno-occlusive disease. Now, this is a echocardiogram of isolated right pulmonary venous obstruction. The right lower pulmonary vein is severely obstructed. You can see the proximal dilated pulmonary vein, the ostium is tightly obstructed. The Doppler interrogation shows that there is some gradient. Now, we need to understand one thing. Whenever only one or two pulmonary veins are obstructed, the body compensates by pushing the blood to the other healthy lung. And so, you will not get a very severe gradient like what you get in triatriatum. In triatriatum, you will get a gradient of 18 or 20 millimeters also because the entire cardiac output goes. Whereas here, about 20% of the QP will get distributed towards the stenotic side, and the remaining 80% will go into the other healthy side. This redistribution will lead to less of gradients. And so, when you are doing the echocardiography, you need not say, I am getting a mean gradient of only 1 meter per second, that means only 4 millimeters of mercury, so it is very insignificant, I can ignore. We need to understand this concept very well. To reinforce it, I'll show you a Doppler. This is the same patient who had right pulmonary venous obstruction that you saw in the last slide. You see what is happening. There is a right pulmonary artery, there is a left pulmonary artery. Color flow is there. Left pulmonary artery is having color flow deep inside. Right pulmonary vein is not having color flow. So that means right pulmonary artery is not getting adequate blood supply. Let us put the Doppler into the right, there is hardly any blood flow. Put it into the left, there is a good blood flow. So what is happening here? There is a compensatory hyperperfusion of the left lung with relative redistribution of the blood. Right lung is not getting blood supply at all. So unilateral pulmonary vein stenosis needs to be given importance even if the gradient is low. So this is an example of severe unilateral pulmonary vein stenosis. You are injecting into the pulmonary artery and you are waiting for the levo phase, and when the levo phase is coming up, you will understand that there is a tight obstruction. See here, all the four pulmonary veins converge into a narrow orifice. So understanding this pulmonary vein stenosis is very important. The methods that are available are sutureless surgical anastomosis or varieties of transcatheter procedures like stenting, drug-eluting stents, drug-eluting balloons, cutting balloons. Uniformly, all this treatment is very bad. Now, this is an example of a patient who had a left pulmonary vein obstruction that I showed in the previous slide. A sutureless surgical anastomosis was done. This is the sternal wires. This is the acute postoperative phase. We are doing an angiogram 2 days after the surgery. So you are injecting into the left pulmonary artery. The levo phase, hardly any vein is seen. So that means even though it is sutureless anastomosis, you can see that the dye is just staying in the left pulmonary artery. That means this is uniformly a bad disease. You see the patient is still intubated, there is a Ryan's tube, there is a neckline. I mean, basically, this pulmonary venous treatment is very bad. This is an alternative method, stenting of the left pulmonary. Everything is bad. Actually, this treatment of pulmonary vein stenosis itself is known to have very poor results. So to summarize, pulmonary vein abnormalities can be total or partial harmless pulmonary venous drainage, triatriatum, single or multiple pulmonary vein stenosis, and atresia. One thing that I missed out was scimitar syndrome. Scimitar syndrome is an isolated anomalous pulmonary venous connection of entire right lung into the inferior vena cava. Sometimes may involve only the right lower lobe. It has got an altered pulmonary venous architecture. It has got a fir tree-like branching pattern, and it is notorious to be associated with right lung hypoplasia, abnormal vascularity to the right lung, sequestration of the right lung, sometimes severe disproportionate pulmonary hypertension, and that is a distinct entity. We diagnose TAPVCs mostly based on echo, but we need to understand not all TAPVCs can be identified just by echocardiogram itself. This is an example of a patient who had some form of severe pulmonary hypertension. However, echocardiogram was not showing any classical finding. See what is happening. All the 4 pulmonary veins drain into one vein. It goes into the left lung, branches like a snake into the left lung, and then finally ascends as a left vertical vein. So such sort of bizarre anatomy can happen in TAPVCs. You can see that the snake-like appearance here. You see that it's a marked tortuosity, and then finally it is going as a left vertical vein. Now, if you go by and like echocardiography, if you find that there is a left vertical vein, but you are not demonstrating a proper common chamber, don't send them for surgery. You put them for some other detailed imaging. Because if the surgeon opens here, he won't find a common chamber, and then he'll be stuck there. The patient will not be able to come off by that. So we need to understand that even though diagnosis of TAPVC is largely by echocardiogram, we should be accepting that echo has got certain limitations. All pulmonary vein diseases are easy to be missed. So a good prior knowledge about all the various forms of pulmonary venous disease is important for diagnosing them. Most pulmonary vein disease have very poor prognosis without any intervention. Even though echo is the most used method for diagnosis, we should not hesitate to use CT, MR or conventional angiography whenever we are in doubt. Thank you.